I'm Dave Kern, and today I'm going to talk to you about the REWARD initiative and how we used it to identify potential therapeutic targets for the treatment and prevention of PTSD. The goal of the REWARD initiative is to proactively use real-world evidence that's currently available to us to explore the performance of existing medical products, and that could include either the safety of those products or potentially unknown benefits of those products that haven't been studied before. And the way we do this is that we use observational data. So for example, at Janssen, we can use 4 large US claims databases shown here, but it can really be any data that's mapped to our common data model. And we use that to look at all associations between all medications, and that's individual RX norm ingredients or ATC classes, and their association with all conditions. And that is classified as based on SNOMED codes, or this can be validated phenotypes. Those phenotypes could be validated by us in epidemiology at Janssen, or it may be external validation that has been done by others. Now, one thing that we have to keep in mind is that we're doing many different comparisons, 1,700 drugs by 10,000 or so outcomes, 17 million different associations being studied. It's important that we keep strong epidemiologic methods when we're doing these analyses. And to do this at such a large scale, we use a self-controlled cohort design, which helps us control for time invariant confounding. We also use negative controls to adjust for any potential residual confounding that isn't controlled for by the self-controlled cohort design. And we also look for strong effects and effects that are reproduced. So we're looking for here at least a 30% reduction in risk of the outcome of interest. And we're also looking for those results to be replicated in at least 2 of the databases. Now I'm going to go through an example of how we used REWARD to identify therapeutic targets for the treatment and prevention of PTSD using this infrastructure. And now, so our goal was to look at PTSD as the outcome and identify any drugs associated with that reduced risk. And as I said before, we're looking at all exposures. That's all potential drug ingredients and ATC classes. And our outcome, we're only looking at a single outcome instead of all 10,000 here, and that is for PTSD. And we define PTSD based on the presence of at least 2 diagnosis codes within a year of each other, and at least a 6-month clean period where patients are enrolled in the database with no evidence of PTSD. Now, this is an algorithm that was validated in a VA administrative claims database by Gayle et al. And we've used it here to create that cohort in Atlas. And before we jump into the REWARD results, it's important that we actually look at who are these PTSD patients that are in our data. So just looking at our Optum database for now, we identified 250,000 patients. And within those patients, we saw that about 2/3 of them were female and about 41 years old on average. And also that comorbid psychiatric and pain-related conditions were extremely common. So for example, more than 1/3 of patients were diagnosed with anxiety disorder, while 1 in 5 patients had a diagnosis of low back pain. So now we're about ready to jump into what we found, what drugs are associated with a reduced risk of incident PTSD. And they really fell into 2 categories. So one is a bucket that we're calling primary signals. And now these are drugs that wouldn't be commonly used to treat PTSD or its symptoms, but they have been previously investigated or hypothesized or proposed as potential therapies, or at least their mechanism of action has been hypothesized to be a potential pathway to prevent PTSD. And the other is a group that we're calling potential signals. And these are drugs that have evidence, plausibility that they could be effective. There's a real hypothesis that could be drawn, but the effects may also be confounded due to off-label use for the treatment of PTSD or for the treatment of PTSD symptoms. And these results may be confounded due to the self-control cohort design that were implemented. And now here's what we found. So our primary signals are a beta blocker for propranolol and a number of different ADHD treatments. The beta blocker, propranolol, has been studied quite extensively as a potential treatment for the prevention of PTSD. Now, it's not commonly used for that purpose right now, so it's interesting that we also picked up its potential protective effects in REWARD. And then the others are, again, a number of ADHD treatments with different mechanisms of action. And then we have that group of potential signals, and they fall into two buckets. One is for drugs used for substance use disorders, and that includes alcoholism and then nicotine for nicotine addiction, and sleep disorder treatments. So these are typically used to treat insomnia. And they're potential signals because both of those things, substance use disorders and insomnia or sleep disorders, are common comorbid conditions in PTSD populations. And so the study design may be confounded due to the temporality between exposure, outcome, and indication for these medications. So conclusions and next steps. The key takeaway here are the primary and potential signals that we just outlined. But really, we're not interested in repurposing these drugs necessarily. What we're really interested in is learning more about the mechanisms of action of these drugs, their biologic pathways, and how that all leads to the prevention of PTSD biologically. And we can use that knowledge to potentially develop a new molecule that is more designed to get at the prevention or treatment of PTSD specifically, rather than these other conditions that the drugs are indicated for. And before we even get into that, into potential molecule development, it's important that we explore these associations a little further, and that could be through observational studies that use new data sources, or even using the same data sources but using a different study design. So can we confirm these associations, for example, using a comparative cohort design? And so that for us are our next steps as we further explore these treatments and their pathways as potentially being protective against incident PTSD. Thank you.